Hello, and thank you for joining the Demands and Capacity team and listening to this recording regarding diagnostic services and the crucial role that they will play in the recovery in the post-COVID context. I'm Vanessa Perez. I'm part of the Demand and Capacity team. I'm one of the technical managers. We are a team within NHS England and NHS Improvement. And I'm really glad to introduce to you today Joseph Tansley, one of the the operational manager for radiology at Sheffield Teaching Hospital. Joseph, would you like to introduce yourself a bit more, please?
Yeah, thank you. So, in terms of myself, as Vanessa said, I'm the operational manager for radiology at Sheffield Teaching Hospitals. I've worked in the NHS since 2003, and obviously my current role is working within radiology. Um, in terms of the organisation background where I work, so it's a large organisation which employs around 7,500 staff. We've got 5 different hospital sites, um, all of which provide radiology services. So, as you can appreciate, it can be quite challenging to provide those services across kind of a large geographical footprint. In terms of the radiology department itself, so we employ around 650 staff, operate within a budget of £33 million, and we undertake approximately 500,000 examinations each year. So, in terms of the presentation and COVID recovery, as a number of you will probably can relate to, 19th of March is kind of the day that things started for me and the impact on services that we provide. So at this point, once the pandemic was starting to begin, really, we started with an increase in patient enquiries and cancellations. So a lot of enquiries about patients, whether they should still attend for their appointment, and starting to see an increase in the volume of cancellations as well. On top of that, we had staff who were beginning to feel ill, staff who were having to go into self-isolation. We also had a lot of debate about whether we should cancel particular procedures or whether we shouldn't cancel them. And as everyone else can relate to, it was a very constantly changing situation where everyone needed to react quite quickly. With that as well, it brought conflicting information from various sources. And as a consequence of that, we had to revisit a lot of procedures and a lot of things that we did. So, for example, in terms of cancelling a large volume of patients, we had to revisit that to make sure that they were cancelled correctly, and so that we'd got a standard process in place to ensure that no patients were lost during that process. So with all of that, all of those issues that I've just spoken about, we ended up with a backlog of around 11,000 patients, which were still waiting for an appointment or had been cancelled. So a breakdown there of the different modalities and the volumes of patients that we had within each of those, just to provide some context in terms of the position that we ended up in. As you can see from this graph, the performance of the 6-week wait standard deteriorated significantly. So whereas prior to February 2020, we had a significantly good performance really across each modality in terms of the 6-week wait performance. And as you can see there, from March through to May, the performance was significantly impacted. So in terms of our approach and how we manage this, so each of the waiting lists for the imaging modalities were categorised into subspecialties for clinical review. So all of the patients which were held on our waiting lists were reviewed by the clinical staff within the department. So it was mainly the consultant radiologist staff, and also we engaged with consultants within the relevant specialties across the trust as well. In addition to that, a number of GPs reviewed a volume of their ultrasound requests, and it was all about prioritising them accordingly and looking at different factors such as comorbidities for each patient, their age, and any risk associated with coming into the hospital for a scan, and their susceptibility to contracting COVID. So there were quite a lot of things that needed to be taken into account in terms of reviewing those patients and prioritising them and balancing those up against the risks. In addition to that, we developed some recovery plans for each of the modalities, and this looked at capacity and the demand. And again, these were constantly changing and having to be reviewed. Whilst we did do a lot of work in terms of managing the backlogs and managing the patients and the service as a whole to continue running a safe service for the patients that it needed essential imaging procedures, there were a number of problems which came up with that as well. So, for instance, with imaging, obviously, it's not something that can be undertaken remotely. So a lot of our colleagues across different areas were undertaking clinics through over the telephone, so doing a lot of telephone consultations. And obviously with imaging, it does require a face-to-face attendance. With that, we needed to carefully plan to prioritise which patients needed to be scanned, and that needed to be introduced in line with other services so that we weren't imaging patients that then were not going to go on to have treatment in a timely manner. With that, we needed to manage the increased use of PPE and infection control measures. And so what that did is impact significantly on the capacity that we were able to provide within each of the services. And on top of that as well, we did lose a number of our rooms that we had available for scanning due to an expansion of our A&E department. So overall, in terms of looking at our capacity then, so as you can see there, each of the modalities within radiology were significantly impacted by a reduction in capacity. Part of this, we utilised capacity from the independent sector to try and increase our overall capacity. So we worked with private hospitals and also sourced on-site mobile facilities wherever possible. As part of the management of the process, we devised a tracking system of demand, capacity and activity that we had delivered. So in this section that you can see on the slide, this is for MRI. And what this does is looks at what our demand is in terms of our backlog and our patients that we have got on our planned list, which are currently due or were overdue. Then alongside that, we've got the capacity that we've got available to deliver each week. And that's broken down by our on-site facilities, and then along with any additional support such as private hospitals or mobile scanners that we were able to utilise. At the end of that, it provides a summary of what was actually delivered. So for each week, we've got the demand, the capacity, and what we were able to successfully deliver during that week. So it helps us to keep a track of the referrals that we've got, what capacity we've got, and then whether we've actually successfully been able to deliver that capacity. And then obviously if there's any shortfall, it's easy to kind of see and try and address that. In addition to that, I revised our weekly activity meetings or modality meetings. And as part of that, I developed a dashboard which contains a number of metrics which are relevant for each area. And this covers things such as the volumes of referrals coming in, what our backlogs are, and the activity that, again, the activity that we've performed both inpatients and outpatients, DNA rates and utilisation of our capacity. And again, that just helps us to keep a track of where we're at and any sort of improvements or any deteriorations in either activity or capacity. And as well, it helps us to monitor the volume of referrals coming in, and again, any changes in referral patterns or any trends. So following that then, in terms of the position that we're in currently, there are still a significant number of patients that are waiting over 6 weeks. However, at the moment, there's about a 10% improvement in our performance in comparison to the May month-end position. So it is improving from the 6-week diagnostic target perspective. Again, we've managed to source additional capacity from more mobile scanners that we've managed to get on site. And as part of this process, we've managed to develop more robust processes in terms of our partial booking and tracking and validating of patients that we've got on our waiting lists. In terms of some of the work that we're planning on doing next, so there's a lot of research out there which suggests that virtual outpatient clinics result in an increase in requests for diagnostic imaging. So this is something that we are tracking quite closely to measure the impact of that. And obviously that's something that we can address as well, or hopefully try to address once we establish whether that is a problem within our services. Last year we had the GIRF data published for our trust, which indicated that demand was higher than the national average within all modalities except ultrasound, and particularly for CT head scans, there's a significant increase in demand, which is significantly higher than the national average. What we're planning on doing next is a demand management program, and this is where we are looking at doing some collaborative working with the clinical staff within radiology and the clinical directorates across the trust. And the intention of this is to kind of look at different guidance, really. So it's reviewing NICE guidance and different views and clinical pathways of various specialties which come into radiology, and looking at where there's any best practice and sort of other research. So the intention of this really is looking at what we can do to reduce the demand on the service. So it could potentially be asking questions such as, if the patient does have this scan, will it actually lead to any different treatment or management of that patient? Or are there any other alternative diagnostics that are available which could potentially reduce demand within radiology? So some work which we have started, and this is looking at MRI requests for knees. And one of the things that we've put in place is that patients should have a plain film X-ray, and that should be reviewed prior to any request being made for an MRI scan. So as part of the referral criteria, we've now put in place within the ICE system that it prompts referrers to look at that prior to submitting a request for an MRI scan. So it will prompt the referrer to remind them that they do need to have a plain film X-ray prior to referring to an MRI scan. One of the other things that we're planning on looking at is the demand and capacity overall. So whilst we've touched upon the different sort of tools that we've developed internally, the longer term plan would be to use the NHS England NHS improvement demand and capacity model. And I think this fits really well with radiology actually, because it allows you to do the demand and capacity planning for examinations using minutes. And obviously within radiology, the different scans can vary in time. So to enable us to provide a more accurate position in terms of capacity, I think being able to show that within minutes, I think would be quite useful. So some of the next steps for us as an organisation is to look at implementing that for each of the modalities within radiology. And also it can help take into consideration the different subspecialties as well. So on reflection, whilst it's been a very challenging time for us in terms of managing the volume of patients and, as I say, the different demands and the different change in position, there has been some positives which have come out of this. So as I say, there's been a great increase, I think, in team and multidisciplinary working. So particularly our admin staff and our contact centre booking team, the working relationships with clinicians has significantly improved. And I think it's a lot to do with people having a shared purpose and a shared goal, and people having to work sort of more closely together to achieve that shared goal. We've also developed a better understanding of data and patient tracking. And I think going forwards in future, a lot of this can help with the development of business cases and the further work that we're planning on demand and capacity planning. We've also managed to implement improved processes around our waiting list management and validation. And we've noticed that individuals at all levels taking more ownership, and that's across the board at, whether the clinicians or admin staff at all levels, really across the service. People have really sort of stood up and took ownership. So that's about it, really. So that's a brief summary in terms of the work that we've done at Sheffield. Happy to help if people have got any inquiries or if they've got any questions about anything they've seen or heard today, then by all means do feel free to contact me. My contact details are obviously on screen at the moment, and thank you for your time.